All right. So today, as I'm sure you all know, we are talking about dengue. But first, I want to tell you a little bit about the Texas Epidemic Public Health Institute. We are a state agency here in Texas. Our goal is to keep Texans safe, economy strong. So we are strengthening capacity and resilience of Texas communities to respond to future infectious disease outbreaks. And even since COVID, we've had some. So we have a lot of collaborations with government agencies, with academic agencies, professional associations, local, state, schools of public health. I'm sorry, health departments, business entities, and then community organizations. We offer, and I will say that all of this is free thanks to the Texas legislature. We have a pandemic preparedness and response certificate program. We offer CE credits for this. As I said, there's no cost for Texas residents. They are asynchronous online courses, and the 4 courses are fundamentals of EPI, foundations of infectious disease, surveillance of infectious diseases, and ending with a public health emergency preparedness and response course, and then a tabletop exercise. So check that out. And you can, if you go to the website, which I will put in the chat, you can find all these resources that we have. We also have some mini courses. These are 1 to 3 hour courses on special topics. You can see these 5 are the ones that are published on data analysis, financial management during pandemics, 1 health, pandemic ethics, and risk communication. And very soon we will have courses, mini courses on advanced Excel, discussing sensitive topics, particularly for epidemiologists who need to do contact tracing, and then analyzing surveys. We also have a yearly public health summit, which is coming up in, that's 2 weeks, I think. This year's topic is preparing for zoonotic health risks. You can register either, if you're here in Houston, you can come in person, we'll give you breakfast and lunch, or you can register online. Again, you can find this on the TEPHI site, which I will put in the chat. And also, if you're fast enough, you can use that QR code. There, as I mentioned, a lot of these free resources are on the TEPHI website. We have updates. We have what's called a Lit Rep newsletter that goes out about what's happening in terms of infectious diseases of pandemic potential. And then other webinars that you may be interested in. So if you need closed captioning, you can click the live transcript. This will be recorded and will come out in about a week. It'll be sent to all the registrants. There's a question and answer function in Zoom to ask a question, and I will ask those questions at the end of Dr. Wellington's talk. You will get a survey, of course, upon exiting, so please do that. Let us know how we did, but also, you know, what topics you would like to see for these grand rounds as well. So, our speaker today, just a minute, I need to bring some, let me stop sharing. Actually, I still want to share. No, I don't, because my notes are here, sorry. All right, our speaker today is Dr. Trevor Wellington. He received a bachelor's in biology from Georgetown University, an MD from Loyola University in Chicago, and did residencies in infectious disease and internal medicine at Madigan Army Medical Center and Brooke Army Medical Center. He is currently director of the Walter Reed Army Institute of Research Clinical Trials Center. So he is responsible for all operations, personnel management, financial planning for the largest clinical trials center in the Department of Defense. He is principal investigator on 2 studies, associate investigator on 3 more for phase 1 to 2 clinical trials. assessing safety and efficacy of military relevant vaccines. And you can imagine with military stationed around the world, there are diseases of interest to the military that we don't think about so much in the United States. He is also responsible for study protocol drafting and recruitment of external, that is non-DoD pharmaceutical partners, and does congressional briefings on vaccines of national interest. So Dr. Wellington, I think you should be able to share your screen.
And thank you, Kathy, for that wonderful introduction. And I wanted to first thank TEPHI for the opportunity to present here. As you mentioned, I did my infectious disease fellowship at Brooke Army Medical Center, completed in 2022. So it's nice to be back in Texas here, at least virtually, as I'm currently now in Maryland here. So before I get started, I just want to do a quick check. Are you able to see my slides?
Yes.
Okay, excellent. So again, thank you for the opportunity. And tonight I wanted to talk to the audience about dengue, specifically regarding that increasing global burden, as well as challenges with vaccine development. It is a particularly emerging interest, as well as military relevant interest, as you already mentioned. As it's a fascinating topic regarding the actual vaccine development and issues that have been run into along the way. So, like you said, I'm the director of the Clinical Trials Center, as well as professor at Uniformed Services University, and then I have an operational role as well too. So, quick disclaimer: views are my own, not those of those who employ me. So you can hold me accountable for them, but not anyone else I list. So, and I welcome feedback, criticisms, complaints, discussion, whatever you want to discuss. I'm here for you. So, and I have no financial disclosures to report either. So I wanted to start off here first with a question to sort of get the gears turning here. And we'll start with a little bit about epidemiology and sort of case reporting of dengue. So where in the continental United States has limited local spread of dengue virus been reported? Florida, Texas, Arizona, California, or all of the above? I'll let you think about that for a minute. If you selected E, all of the above, you are correct. As often is the case when all of the above is an option, you should probably choose it. So we have seen local transmission of dengue in a couple areas in the United States with limited local spread in the above states. The largest amount of dengue spread in the United States is actually going to be in a lot of our territories. Puerto Rico is the major site that I'll go into, but we're also seeing limited local spread in these areas as well. And then the actual islands and other territories that are located in other endemic areas have much higher burden. So a little bit about the virus before we actually go into further details about the epidemiology. So dengue is referring to the disease of dengue virus. So there's 4 subtypes of dengue virus. There's 1, 2, 3, and 4. They keep it pretty simple. And this is in the flavivirus family. And you can see here a breakdown of some of the other viruses in the family. And one that's left off of here that I also wanted to mention is Eastern equine encephalitis is also within this family here of flaviviruses. And I know it's been hot in the news, and we'll go into a little bit about the differences here between dengue versus Eastern equine encephalitis, because I know hot in the news, but we also need to consider dengue as very relevant as well. So with that, another question to keep the gears turning is what type of mosquito actually transmits dengue virus? And we start to consider, okay, if we're thinking about ranges of these diseases, we need to consider the vector for which they are spread. So I've included the names of some species or genii here, as well as some associated pictures. So I'll give you a moment for attendees to take a look. C for extra credit, if you can match the picture with the type of mosquito, as this becomes important when we're thinking about, well, why are these diseases spreading where they are, especially regarding Eastern equine encephalitis as well as dengue. So
Can
you've
you
had a
see
moment
the
to
chat? Can you see the chat, or you want me to call out some answers?
Oh, I cannot see the chat. I
Okay.
apologize. I've been so
Yeah, so
focused.
let me tell you, we've got a 1E, 1A, and then someone said LA County just had their third locally reported case. We've got a C for Culex, a couple of Aedes,
Perfect.
3 of them, I think, another Culex, and
All
A
right.
and C, so the answer must be E, pertaining to the hint you gave earlier.
Well, credit to those who, let's see if I can get, selected the 80 species. So the 80 species is going to be the choice for transmission of dengue, as well as some other arboviruses, specifically chikungunya, yellow fever, and Zika. And the 80s mosquito has that, I think of the oil well drilling straight down sort of phenotypic appearance to it. That was the memory trick I had for myself. The Anopheles species is the malaria mosquito. So that one, a little bit different distribution, and the primary organism and disease is malaria for that. The Culex mosquito is a lot more of those diseases we think of as around America. And if you're seeing a brown mosquito in your area, it's likely going to be one of the Culex within the Culex family. That's what's carrying West Nile. Eastern equine encephalitis is one of the subtypes, as well as Japanese encephalitis and St. Louis encephalitis. So you can see that the appearance of these can help you sort of distinguish what diseases they may consider. If you see a black and white striped mosquito, probably thinking about 80s. Whereas if you're seeing a brown mosquito, thinking more about Culex, and hopefully you're not seeing any Anopheles around here with raising a concern for malaria. So
I'm sorry to interrupt, but could you tell us when they bite? Because I know it's different times of the day, but I never remember which is which.
Yeah, absolutely. So the Aedes and Culex species are generally dawn and dusk. I apologize, I misspoke. The Anopheles species is generally dawn and dusk, where if you're out in sub-Saharan West Africa, it's best to really be careful at breakfast time and dinner time. Whereas the Aedes species is more midday biter. If you take your kids to the park in the middle of the day in summer, one, I'm sorry, because you'll be very hot. But two, you should be also watching out for the Aedes mosquito. Similar with the Culex, though the pattern of bite, while I try to think about that when seeing these individuals clinically, I put a little stock, but it's still, if someone says, oh, I was only bitten at night, I still need to think about the other arboviruses kind of thing. So, and other mosquito-borne diseases. So a little bit about the transmission. So when the mosquitoes, with the primary vector being the Aedes aegypti and albopictus, actually bite and take in the arbovirus, the dengue arbovirus, it typically takes about a little over a week to then become infective to the point of being able to transmit to a human. Now, these mosquitoes have generally short lifespans of 1 month, so you can imagine there's a limited relative window, but in the course of this lifespan, it can be significant. And then with regard to person-to-person transmission, this is where you think about, okay, symptoms are coming on at the point of viremia, reaches its maximum about 7 days. And there is a possibility for bloodborne transmission at that maximum. Now, important to remember, especially when from a public health and talking with patients, is that it's not going to be transmitted by respiratory droplets or sexual conduct in general. So important for counseling purposes. So with regard to actual symptoms after being bitten by a mosquito carrying dengue, about 1 in 4. So that's the number I think of. There's only one number to remember, and that's 4 for people getting sick with dengue. And we think of the symptoms as breakbone fever because it is very, very clinically significant bone pain, muscle and joint pain. Where if an individual has a fever plus bone joint pain that said, "Oh, this is the worst of my life," and I'm barely able to get out of bed, that's what makes a sort of trigger for dengue thinking about, particularly when someone has been traveling to an endemic region. There are some other symptoms involved. These are a little bit more difficult to distinguish from some other insect-borne diseases as well as other, upper respiratory viral infections, a little bit more generalized. But one I will point out is the tourniquet test is a frequently encountered and pathognomonic finding. I included a picture. There's some severe pictures out there on the internet. I chose to go with one of the more mild because it's more reflective of what I've seen. And you can see it almost looks like a little bit of an eczema breakout, but what that actually is a little bit of petechial hemorrhage there at the site when the blood pressure cuff is actually clamped down. That capillary leak and breakage leads to these pinpoint hemorrhages at the site where there's been pressure. So, and that can be either by blood pressure cuff, other separate tourniquet. I've seen it done a couple different ways. So, well, who should we test, especially when thinking about, emerging global burden here is really consideration of travel at this point in time, or being in an endemic area. And we'll go into where that might be, but then that plus fever should really have someone thinking, okay, dengue. Also want to emphasize considering time of year. If in northern hemisphere, we want to think about the summer and adjacent months, sort of May to September, as going to be higher burden for mosquito bites and therefore higher risk. And then considering, okay, the inverse is true for southern hemisphere, particularly the further south you go. Now, for testing of dengue, right now, the acute phase can be diagnosed with PCR testing or nucleic acid amplification testing. Fortunately, a lot of the tests I've seen also come with other arboviruses. It's an arboviral panel is what we've been using in the military health system, where you're not just testing for dengue, you're also getting chikungunya as well as Zika seen in there as well. IgM will typically be positive in the acute stage, and then can be persistent for really up to about 3 months before you should expect those levels to go back down. Also, the NS1 ELISA test, I've read about it and been more experienced with the PCR testing. But either that or the PCR, if positive, you have a diagnosis. If the IgM is positive, that'll just be presumptive. Best to get then convalescent testing. The IgG testing is there's a 2-step algorithm for that. It's a little bit more work to try to get to a diagnosis, and it has difficulty distinguishing between acute and prior history of infection. So really, by the CDC guidelines, utilizing PCR, NS1, or IgM will be the go-to for clinical laboratory diagnosis. Now, we talk a lot about the serotypes. I mentioned earlier there's 4 serotypes. And with exposure to one serotype, you'll get typically mild disease, that 1 in 4 individuals will have mild to moderate disease, where we're having the fever, maybe some of the systemic symptoms, and that bone and joint pain. And then you subsequently develop long-term immunity to that serotype. And short-term protection, mild level of protection against the other viruses. The problem is then the immune system gets primed for subsequent dengue exposure to the other serotypes. For example, if you initially got infected with dengue 1 and then recovered and then got exposed to dengue too, well, your immune system, particularly your IgG response, is already primed and ramped for more significant immune response, that serotype dependent immune response. And the risk is that you then have severe dengue or dengue hemorrhagic fever. And the risk is greatest for that second dengue infection, but can really happen first, third, or fourth infection. So this also becomes a challenge when we're doing vaccine development, because that first exposure can be that vaccination. So are you preventing illness or just priming the immune system for subsequent severe disease? And we'll go into some of the history of the vaccines in development regarding exactly that problem. With regard to dengue hemorrhagic fever, is really that you have an overwhelming immune response to the point where you have such plasma leakage that fluids are going into the third space, as well as you're having hemoconcentration and approaching cardiovascular collapse. You can also see loss of platelets with thrombocytopenia. And in the most severe cases, it will be dengue shock syndrome. And what's interesting about dengue shock syndrome is, although you have an infectious etiology, it still has more of a hypovolemic appearance versus a septic patient may have more of a warm appearance with a bounding pulse with low blood pressure. With dengue shock syndrome, it's really that weak, thready pulse, cold, clammy skin because of such severe plasma leakage and loss of intravascular fluids. Now, how about dengue in pregnancy? This question has come up particularly considering one of its fellow arboviruses, Zika, has been associated with congenital abnormalities. And a study of those with dengue, as well as pregnancy, demonstrated there's a possible association. In this study in South America, they looked at a lot of births, and they found that a small percentage had congenital abnormalities. And then they looked from there to see, okay, with those, how do we compare those without confirmed dengue versus those that did? And they saw that there was a greater frequency of neurologic congenital abnormalities in those with dengue versus those that did not. That being said, the overall incidence was that still very low. The conclusion reached is that, there probably is an association we're seeing here, but it is at a lower frequency from Zika and an overall low rate. So that's regarding dengue in pregnancy. Now, getting to that increasing global burden, we've seen quite the rise of dengue globally, including a 30-fold increase in the past 60 years, with undoubtedly increasing uptick with years to come in the absence of a largely distributed and executable vaccine available. And you can see the general trend here overall regarding dengue cases throughout the world by the WHO. Now, is there a possibility of underreporting and unawareness or lack of testing? Yeah, absolutely, certainly. But what we do also know is that the vector's environment and habitat is expanding particularly into the northern hemisphere, and from its typical southern band that we'll look into, that is really helping drive these numbers up as it gets into a new population that's otherwise been naive to these diseases. So that is driving a lot of these numbers. And you can see even from the year 2000 with 500,000 cases reported, we're up to 6.5 million cases worldwide with 7,300 dengue-related deaths. And I already discussed a little bit about the why behind this, but more specifically, we always think about, well, why are there outbreaks this year, but not every year? It seems to happen in cycles. And the most recent outbreak right now is being traced to, well, multiple factors, but the 2023 El Nino phenomena has precipitated increased rainfall, humidity, and warm climate, all of which really work in favor of expanding the 80 species habitat and range. So that has been tied to why recently has there been such a significant uptick. Also, there seems to be a cycle for outbreaks. And with the preceding outbreak being in 2019, it's thought that there's waning immunity in that endemic population that then subsequently upon re-exposure leads to an outbreak level. Other factors that have been cited are the fragile health systems from COVID-19, sort of fallout features from that, as well as geopolitical instability in these areas, high population movement secondary to humanitarian crises. But if I were to pin it on one driver, it's expanding of the vector's habitat range. As you can see on the graphic here, the barriers are just creeping in both directions, both north and south, to the point where you can see that, hey, that's a good portion of Texas involved, if not a good amount of the southern United States. So this in this year, we've seen that there's increasing number of countries that have frequent or continuous risks. These are areas where, regardless of time of year, you may consider that, okay, you're in a dengue endemic area. And you can see this is in 2024, the amount of areas covered. And the sporadic or uncertain risk, this is still considering that locally acquired. That's versus your arriving travelers, your individuals who may have gone to a separate area and then come back, bringing dengue to that area. And you actually see some areas of southern Florida are actually identified as such. I'll also point out, from a military relevance standpoint, aside from the current geopolitical situation, these are a lot of areas where we have U.S. service members who are, okay, you're not just going for a 2-week trip, you're going for several months, if not moving to these areas. So it becomes an increasing concern of, okay, even though the U.S. maybe at its current state, the use of a dengue vaccine may not be feasible from a sort of economies of scale size. For the military population, it's a little bit of a different ballgame, but more to follow there. So this year, we are currently dealing with a dengue outbreak. In June 2024, the CDC issued this health advisory regarding increased risk of dengue virus in the United States. Now, specifically, we're thinking about Puerto Rico, as they've declared a public health emergency of nearly 1,500 cases and a higher than expected number to be that have been identified in U.S. travelers to that area. So you can already see that within the Americas, cases are way higher this year, as well as in Puerto Rico, where there's good awareness and tracking and as a known issue, that there's already higher than expected numbers. And to that end, the dengue vaccine, Dengvaxia, has been started for administration in Puerto Rico. Now, there's some issues with Dengvaxia regarding the actual production line, but it appears that there's been no issues with the rollout in Puerto Rico for this acute public health emergency standpoint. So if you're contacted regarding an individual where either they're saying, I'm concerned I have dengue, or, you're contacted by a physician who says, oh, I think I have someone who has dengue. Well, there's a couple clinical considerations to have. This, again, is one, are they symptomatic? And two, have they been to an endemic area? really 14 days is going to be the cutoff regarding, all right, at what point do we say, now you were just briefly in that endemic country and come out, and therefore have a lower risk versus, oh, okay, you were there an extended time, you may have had a significant exposure. So we talk about, okay, this is within 14 days before the illness onset. Making sure to order the appropriate testing. Again, my experience with the military health system is PCR is going to be your easiest to obtain, quickest turnaround, and highest diagnostic ability here. But the IgM as well as NS1 tests are also available and may be utilized. It's important for timely reporting of dengue cases. There's an entity, ARBONet, which is the tracker that the CDC utilizes for tracking all the arboviruses: dengue, chikungunya, yellow fever, Zika, Eastern equine encephalitis. That's how it's tracked. So when a report goes in that there's a case, it's ARBONet that then subsequently is compiling the data for producing the nice graphics that they have. And that's why that timely reporting is good, is so that we can be further educated on the true local burden of these diseases. Importantly, prevention at this point is really, particularly for your US population, is going to be preventing mosquito bites, using bug spray, avoiding times of day and areas where mosquito bites are going to be frequent. I know I like taking my daughter to the park. However, on days when there's a lot of mosquitoes out, for the discomfort I avoid, and although the dengue risk may not be as much, it still goes through my head. So really prevention at this time is going to be that preventing the bites, particularly in areas with frequent or continuous dengue transmission. So 2024, I borrowed some information from the European Center for Disease Prevention and Control. And at this time, they're seeing 12 million dengue cases globally and 8,000 dengue-related deaths. And the Americas, as you can see, predominantly South, but also Central and Lower North America are also seeing a significant burden. There are, in Europe, they are seeing some locally acquired cases, specifically in France and Italy. And they consider that there is a risk for then subsequent transmission in that area, secondary to a warming climate with increasing humidity for this area. Now, hopefully, as we progress to the fall and winter months and things cool, the habitat for these the Aedes mosquitoes will decrease in that time period, so that we see an overall decrease during that time. But we should also think, okay, what about the summer months of 2025 in the Northern Hemisphere? So wanted to provide that as a little bit more global context for dengue. And I want to get a little bit closer. So I'm always thinking, all right, well, global burden, what about backyard? What about at home? So the cases reported in the US, and you can see the 2024 map on the bottom left, the majority of these cases have occurred in folks traveling from a dengue endemic area. We'll occasionally see local transmission, as we discussed at the onset of this talk, and it's really where we should always be considering: do we have travelers to areas like Puerto Rico, other territories, and such? And I was curious myself about Texas, that there's been 40 reported cases thus far. And then zooming even closer, you can see that they break it down by county where cases have been reported. I believe Harris County looks to be around 2 adjacent counties with it. My prior county, Comal County, looks a similar circumstance in between 2 areas where there's been reports. So you can imagine just the knowledge of that it's there suggests, okay, we should have a clinical concern, which supports the CDC's health advisory. So trying to make it a little bit more personal for us here. So that's Texas's current status regarding it. Now, the question came about, what about Eastern equine encephalitis? Big in the news. I think I saw in Good Morning America an article, and then had several family members reach out to me about it. So I wanted to highlight some of the differences right now. And it all comes back to different vector, because this is going to be that different species, that Culex species. And it appears that the Culex species has more favorability towards a bit of a cooler, damp climate compared to the Aedes mosquito. As you can see, the cases that have been seen in 2024 have been in this northern area here of the United States, as we probably are all well familiar, in the New England area and then in Wisconsin. Of those cases, so I think what grabs a lot of people's attention is the severity of disease, where the 8 cases that were reported were all the encephalitis cases, the neuroinvasive cases. It's estimated that only about 5% of those result in encephalitis. So with that, you can consider, okay, maybe we're dealing with a much larger a larger number than is being reported of actual Eastern equine encephalitis cases. That being said, now that it's in the news, anticipate a higher number of testing questions about it. With Texas specifically, the only county where we've seen positive testing in non-human activity has been Houston County. And when I say that non-human testing, human activity, referring more to the other hosts for the disease, specifically like birds is the common other host that will often be tested. So that's the comparison for Eastern equine encephalitis. And it remains to be seen regarding as the climate gets a little cooler in the middle half of the United States, if we see any progression southwards from the current range. But there are some distinct differences between dengue and Eastern equine encephalitis. And again, mentioning the vector here. So if you're seeing the brown mosquitoes, that's when you think more about the West Nile virus, Eastern equine encephalitis, St. Louis encephalitis, whereas the black and white, the tiger mosquito, that's going to be your Aedes mosquito, thinking about dengue, chikungunya, Zika, yellow fever. Okay, so I asked myself, well, I get told to report this disease. What does that actually look like? And what's the timeline and turnaround? So I actually went through the Harris County public health reporting system to see, okay, what would the average clinician encounter? So I was able to track down through the Texas Health and Human Services that it's really captured as arboviral infection. So this may be important guidance for those who ask questions, oh, I can't find dengue. Well, okay, take a step back and see that it'll be considered under the arboviral infections here, and that reporting would be within 1 week. Regarding reporting instructions, I pulled up and screenshotted the infectious disease report that I believe would, if I were a clinician in Harris County, this would be how I pursue. But I'm welcome to any feedback on how that might be, because being in the military, we do get questions from all over regarding infectious disease guidance, where folks will ask me, hey, how do I report this in Texas? So I welcome any feedback there, and I've included this as a prompt for further discussion. So we'll welcome any of that for folks either now or at the conclusion. So from the increasing global burden, I wanted to progress and talk a little bit more about dengue vaccines, because there's an interesting history. There's a very interesting current stance point where we're at with vaccine development. And right now, we have one FDA dengue vaccine. That's Dengvaxia, produced by Sanofi Pasteur. There are other dengue vaccines out there that are in various stages of development and approval. And I'll hit on all of these regarding where they stand, their slight differences, advantages, disadvantages, and sort of the way forward here. And this is also with the caveat that there's been a lot of paradigm shifts with vaccine development with regard that have come about from the COVID pandemic. Sort of a lot of new understanding of how to develop vaccines, use of mRNA as a possibility for vaccine development. So I anticipate more to follow. But we are actually at an interesting crossroads here. So first, Dengue. So this is your live attenuated tetravalent vaccine. FDA approved in May 2019. It's actually adapted by Sanofi from the previously developed yellow fever vaccine and administered 3 doses, 0, 6, and 12 months apart. Currently FDA approved for those aged 9 to 16 who importantly demonstrated prior dengue infection, by which I mean you need to have that PCR or NS1. The single IgM is not sufficient for receiving dengue. Additionally, needing to live in an endemic area. So right now, there's no, if a traveler were to come to you and say, oh, I'm going to Puerto Rico, it's still not FDA approved for that purpose. Additionally, some of the questions regarding prior exposure come about. This is one of the significant issues for use in the military, because yes, we have folks who are going to dengue endemic areas, but the prior dengue infection does not apply to the vast majority of service members who may otherwise, you may think about going to deploy or be stationed in a dengue endemic area. So a challenge for subsequent rollout from that standpoint. Even more so, a little bit of history regarding dengue. So there's a significant issue regarding the dengue failure in the Philippines that then subsequently precipitated, it was determined to be a good amount of the vaccine hesitation with COVID-19. And what ended up happening was the vaccine was developed, Sanofi in partnership with the Philippines, then subsequently vaccinated a good number of children as well as some adults. Then that was then subsequently determined to be the primary exposure. 154 children then died during the study, with 19 being confirmed to be due to dengue. That subsequently the vaccine was the primer, and then to an otherwise naive population, and the subsequent infection, whereas we thought the vaccine would protect, actually led to a boosted overwhelming immune response. This had quite a lot of press around it. You can see some of the protests in the bottom right corner here regarding that, and then the fallout effects regarding other vaccines and subsequent outbreaks of otherwise controllable diseases that folks would otherwise have vaccines for. Now, on top of all this is that just recently, Sanofi Pasteur announced they would no longer manufacture dengue. So now we're caught in a tricky place where the one FDA-approved vaccine for a disease is no longer being vaccinated. When we have a disease of increasing burden with likely greater US exposure, as well as globally, without an FDA-approved vaccine to combat it, with our greatest guidance being, well, avoid getting bug bites or mosquito bites. Now, fortunately, it looks like there was a consideration of, okay, we currently have a outbreak in Puerto Rico, so they did address that they're working with the Puerto Rican Department of Health, but it does raise some questions about, well, where are we going from here? One FDA-approved vaccine, and you're not making it anymore. What are the other options besides just not getting bit by mosquitoes? Because we'd hope that for a viral pathogen, with especially if developing vaccine technologies, that we can develop a product that will combat dengue. So that leads me to the other most developed candidate for dengue, And that would be Dengue. This is Takeda's product. This is a recombinant attenuated vaccine that has dengue 1, 3, and 4 on a type 2 backbone, administered as 2 doses 3 months apart. And it does appear to have good safety and long-term efficacy against all 4 serotypes, even in those previously exposed, but then also against certain serotypes in dengue naive individuals. This is where I start to think, okay, well, what about the US population, where this may be relevant? Because of limitations of the seroprevalence of the other strains 3 and 4, there was limited ability, particularly for 4, regarding calculation of how efficacious it was. And for dengue 3, determined it was safe, but not efficacious. So then I start to think, well, okay, how about the US audience? It seems this would be good for non-endemic populations as well as endemic. So regarding authorization of this vaccine, authorized by the EU in 2022, there's other countries abroad in both Europe, South America, and Southeast Asia that have approved usage. And Takeda then subsequently submitted an FDA application for FDA approval, but was subsequently withdrawn in July 2023. This was due to a back and forth between the FDA and Takeda regarding data analysis that the FDA wanted and was not necessarily collected as part of their phase 3 trial for studying the safety and efficacy. So as essentially Takeda said, no, we'll come back to this with regards to the information that's being requested, is my understanding. So this raises my own thoughts. Okay, well, with the manufacturing of Dengvaxia being stopped, well, how does that impact your other most developed candidate? Will we see a further push for Qdenga to receive that FDA approval? That is well above my pay grade, but it does make me wonder about that, particularly because the relevance of the vaccine to the non-dengue endemic populations, such as U.S. Foreign travelers, as well as a military population. There's other vaccines as well here that are at various stages of development. NIAID has developed a single-dose live attenuated vaccine, TV003005, in late phase 3 trials and has ongoing trials in Brazil. But again, similar issue to what was encountered with Qdenga, in that there's limited seroprevalence of dengue 3 and 4 in the area where the study is going on, that hampers that evaluation. Now, additionally, there is another product that's has been and continues to be developed with RARE, Walter Reed Army Institute of Research, for which I'm currently stationed at their clinical trials center. And this is the purified inactivated vaccine, currently in phase 2. And the phase 1's demonstrating safety and various approaches to how to vaccinate. 2 doses of the same vaccine, a prime boost strategy where you do the purified inactivated vaccine, then a live attenuated vaccine. So more to follow with regard to that product in partnership with GSK. Finally, wanted to also mention the V180 recombinant subunit vaccine being developed by Merck. This is using a envelope protein against all 4 from all 4 serotypes, and is currently in phase 1 study. So there are other candidates out there, and I'm also excited to see what some of the lessons learned from the Operation Warp Speed and COVID vaccine development, how that will inform other diseases for which we still need to improve vaccines for those. So I wanted to leave it there and open up to questions that I hope I can develop, as well as take a chat, take a look at the chat here that I've I apologize for having disregarded while presenting, but am catching up now.
Yeah, if you can see them, that's great. Otherwise, I can repeat the questions. Can you see both the chat and the Q&A?
Let's see. I've got the chat up here. Oh, there's the Q&A. Okay.
Okay.
Excellent. Oh, I apologize regarding the Eastern equine. Yes, alpha virus. Apologize for that slip. Regarding if there's any trapping or testing of dengue virus carrying mosquitoes in areas where mosquitoes are more condensed, yes. I can speak from the military standpoint. There's ongoing efforts from our entomologist regarding trapping and testing of areas, and they get a lot of their reps done locally, and therefore then subsequently testing. But results have otherwise not further been pushed out to me. So yes, it's going on. Wish I could report more on the results, but that's where we're at. Thank you for the clarification here regarding the dengue cases acquired by travel. Yep. So regarding the Dengvaxia dose 1 to dose 2 and 3, then precipitating the subsequent hyperimmune response, essentially. In theory, yes. In practice, it was more than subsequent natural exposure that led to that. Yeah. Most common strain reported in the U.S. So this is a tricky question because so many of these are imported cases that we said. So you see a heterogeneous presentation of serotypes. Most common are going to be 1 and 2, similar to where we see the highest burden. But it wouldn't necessarily beget that, okay, then with subsequent spread in the area that, okay, this is a dengue 1 region versus dengue 2. Does the U.S. military work with other militaries in infectious disease research? Yes, absolutely. And this actually, I'm seeing the other question too regarding seroprevalence of other serotypes. So yes, so U.S. military specifically, Walter Reed, the Research Institute, has branches in Africa, in Kenya, as well as Thailand, where they have a partnership with the Royal Thai Army at the Armed Forces Research Institute for Medical Sciences, AFRIMS, where this is exactly why we have those set up, is that we can then subsequently progress to phase 3 testing in an endemic region of U.S. military developed products. That's the idea, to then get subsequent exposure. And with collaboration for other militaries in the Western Hemisphere, we have a really good relationship throughout Africa and Kenya specifically, through HIV work with PEPFAR, the President's Emergency Plan for HIV. Oh my gosh, PEPFAR is our HIV research funding. I apologize. That's where a lot of good relationships have already been established, is through that HIV work and AIDS relief, Plan for AIDS relief. And then subsequently from having those relationships, then can progress on to other research, especially malaria, for which the military has a lot of historic experience, but then for other diseases, including the arboviruses. Other opportunities in Western Hemisphere, there's also partnership going on in Central Europe, not quite Eastern Europe, well, in Tbilisi, Georgia. So you're getting pretty darn close to the area of conflict, where there's also ongoing research for tick-borne encephalitis. So a little bit different of your insect vectors, but there are a lot of partnerships going on. One area that could be further emphasized, and the Navy has more of a presence, is in South America, where they have a research institute in Peru, where they're doing other infectious disease research. How does one get started in research working in the military infectious diseases? Are there opportunities for non-military young scientists to get involved? Yeah, absolutely. There, especially for those either with, if you have people in mind in Texas, it's going to be through Brooke Army Medical Center, would be a great opportunity for further collaboration. And I'm happy to put folks in touch, both with surveillance as well as then development of therapeutics, vaccines, and other investigational products. Appreciate the feedback, Jason, regarding the reporting. Why some folks are bitten more than others? Oh, if I could put I would be a millionaire if I had the definitive answer to that. There is postulated certain pheromone expressions that we're still determining. Okay, what is it? But the exact science behind it, we're still waiting on a definitive answer. So all I can say is continue to use mosquito precautions, especially around the wrists and ankles in the evening and morning and evening. Thank you for outlining PEPFAR, as I blanked on that. Then 1 and 2 for your most prevalent serotypes. Risk factors for hemorrhagic disease. Yes, so your reinfection with a different subtype is going to be your greatest risk. It's appeared dengue 1 and then 2 are the that series seems to be some level of risk, but can really happen at really any interval, any stage of infection. But it's really that second infection overall, regardless of serotype, that will put at risk for hemorrhagic fever. Is there a way to get in contact with you about BAMC opportunities? Yes, absolutely. And happy to tie in there. If you could reach out, I will put, let's see if I can, I'll put my email in the chat here, or it can be emailed out. I'm happy to share address. Anyone with any questions.
Your phone number is on the slides as well, correct?
Correct.
So they will,
yes.
They will have that once you can write it down now or when we send out the recording.
Perfect. Okay. Looks like we are at time here. Kathy, I wanted to touch base with you here. Is there any other pending questions or anything to address?
It's a little hard going back and forth between
yeah.
There was one I just saw in the chat and now I don't see it. I think this is a quick one to answer. Are you doing whole genome sequencing at Walter Reed, and have you seen any mutations?
Yeah. So yeah, the whole genome sequencing taking place through we have a viral diseases branch, which one of their emphases is on dengue. A lot of their work got taken up by COVID, but they're still doing dengue. And regarding mutations, I would need to check with them regarding specific mutations or suggesting like variants of serotypes. I'm not sure we're there yet with regard to just not having the seroprevalence to then subsequently look, okay, how does this virus compare to this one in the future from our US population? But I can reach out to them and put you in touch with regard to that answer with my contact in the viral diseases branch.
All right, well, thank you so much. We are at past time. Thank you so much for such a great presentation of a topic that we're seeing more interest in because we're seeing those increasing cases. So thank you very much for you, the participants. I hope to see you in 2 months for our antimicrobial resistance talk. And again, please fill out the survey. If you have topics you want to hear about, let me know. We'll arrange it. So thank you very much, Dr. Wellington.
And I wanted to thank you again for the opportunity to present. It's a topic I enjoy talking about, and also it gave me fond memories of Texas. So thank you, everyone.
But not dengue, I hope.
Exactly. All right. Thank you very much.
Bye-bye, everybody.